Good morning. This is Karin and Christy here to explain the new stroke flow sheet that will be coming to you this week. We are starting with an ICU patient, but do know that this flow sheet will work for the tower patient as well. There will just be some things that you will not select. So first off, we're starting just in your patient in your general flow sheets, and we'll select the flow sheet. The title of the flow sheet is called Comprehensive Stroke. So it's best if you type in stroke, and then theoretically it will show up on the preference list tomorrow. However, for now, you can search it in the database list and then select Comprehensive Stroke flow sheet. When that flow sheet pops in, you will see at the very top your dysphagia screen. So if that has been completed in any unit, that information will follow through and flow into your chart. If that has not been completed, you will of course need to complete your swallow screen. The one thing to note is that, as we all know, patients' symptoms fluctuate. So you'll want to make sure that before you give anything, the patient doesn't have any new symptoms. The other important piece of information with the swallow screen to remember is that patients can still aspirate even if they've passed a bedside swallow screen. So while this is helpful, it's meant to really be able to administer medications that are necessary. Our process is that here at Deaconess is that speech therapy will still see the patient. So if the patient has any symptoms that automatically fail them with the swallow screen, such as slurred speech, facial droop, wet secretion, so on and so forth, then they fail and we do not proceed with their swallow screen. This does not mean that they don't get medications, however. So if this occurs, you do need to let the provider know and look for an alternate route for medications. Now we move on to the NIH. Our process is that with the NIH, it is completed initially by a provider, either in the ED, myself, maybe a neurology provider, or the 11 tower RN if they're responding to a stroke activation, assuming that this is an activation patient. If not, you will need to complete an NIH before any intervention. Again, if this patient had this done in the emergency department, that information will flow through. So we can just run through this NIH. It's going to function exactly the same as it did before, with your completion at baseline at 2 hours after treatment, and then again, Christy, and then at 24 hours post-treatment. So if we have our baseline, their level of consciousness, Christy, you can just pick whatever. Okay. It doesn't matter. Make it good so that they get therapies. There you go. We have a sick patient right here. Okay, so we have an NIH of 32. I've never seen that. That would be bad. That patient obviously needs some intervention. So with our vital signs, you can see next, right here, that information again will flow from everywhere in the chart, but we can go ahead and complete this information. Perfect. Now, we're going to skip the neuro assessment for just a moment, and we're going to scroll down in the flow sheet to intervention. You can see here, therapy received. So you will cascade that if the patient receives any stroke intervention, such as alteplase or thrombectomy or coiling for a subarachnoid. Now, this does give the option that if your patient has both therapies, you will select both options and add those. So we're going to go ahead and select both. Okay. So once you've accepted that, the sheath removal or sheath information needs to be put in there. Now that typically is done by the cath lab, but we want to make sure that if it's not, we want to enter that information. So we're just going to fill this in so that you can see.
Let's say it's 10 French.
Yeah. Femoral.
And it's on the right side.
Perfect. Okay. So at least that gives us that information. So now we have here at the top our thrombolytic adverse reaction assessment. We also have our sheath assessment and our pulse assessment. So the minute the sheath is pulled, often in IR or the cath lab, this documentation will ensue. So we'll go back up to alteplase. Now, every single check that the patient has alteplase, this adverse reaction assessment needs to be completed. So for the 15-minute alteplase check, when you continue down the screen, let's go back up to neuro. Oh, sorry for my finger. So now your patient has had their baseline NIH. We will complete a neuro assessment for every check until the 2-hour NIH. And then for every check until the 24-hour NIH. So we can go ahead and fill in this information. You can just select Christy.
Mm-hmm.
So your GCS calculates, your level of consciousness comes in. Now we have pupils. This is different on the Puget Sound side right now, and this will also be different in the Tower patient. So over here, you can see that we have our options for pupillometry or pen light. If you are using pupillometry, you will select pupillometry. If you're using pen light, you'll select pen light. So they are single select options right now, so go ahead and select. Now, all of that information cascades in, so you can put your pupil size, your NPI, so on and so forth, all the way down. Okay, that is included in the neuro assessment. Now, swallow evaluation is in the neuro assessment. You may or may not necessarily need to complete this, but again, remember that every patient can have fluctuating symptoms, and so they may have passed a swallow eval and they may potentially fail or have a change in symptoms that would preclude giving them something orally. So you just want to make sure that you're cognizant of that. And then we'll just move on down through the focused neuro assessment. When you have a patient who is intubated and sedated, you do need to lighten their sedation in order to be able to complete the assessment. And I know that that can be sometimes cumbersome, but it is very important, especially if they've had alteplase, that we make sure that they don't have any bleed. And allowing them to remain sedated and bypassing this assessment does not benefit the patient in any way. Okay, we can go ahead and just fill out eye position. Good. So your options. I'll try and make this screen a little bit. Here you go. Perfect. Now this is, using the focused neuro is a bit of a process change for us here at Deaconess, where previously we used to use the modified NIH on the old paper format. But this should make things easier for you guys. If your patient has any seizure activity, you'll go ahead and cascade that information down. If they don't, then you can just simply select no. If you select yes, did you select yes?
I did.
Okay, then it should cascade, correct?
Mm-hmm.
Okay. Okay. If they don't
This
have...
is the seizure activity down.
Oh, down below.
Mhm.
Gotcha. If they don't have any seizure activity, then obviously you select no. Corneal reflex. If you do that, Babinski again. Nuchal rigidity and gait. Now, if they're post-alteplase, you may not be getting them up to ambulate, and that's fine. You just simply say not tested. Now, if your patient has seizure activity, you would go ahead and complete all of this seizure activity questions.
And you guys know how to fill that out. We're just going to skip over that and move on.
Yep. So now we come down because our patient received both alteplase and thrombectomy. Again, you can see they're double selected, and we've already added those interventions and cascaded that information in. So you would complete all of this information. Do they have bleeding? Yes or no? If they have bleeding, where? Minor or major? Swelling. Do they have angioedema? Do they have lip swelling, tongue swelling? Yes or no? Our poor patient does. Face, lips, or tongue are our options. Now, airway. Is it patent? Do they need to be intubated if they are not intubated? Perfect. Any change in mental status? This would be indicative of any bleeding in the brain. Or new onset of headache? Yes or no? We select yes. Then it's asking, what are your interventions? Your interventions are stop alteplase, notify provider, or other. Now, certainly in this instance, you're going to stop alteplase and notify the provider. Nausea or vomiting? Perfect. High blood pressure that you are not able to manage? New or increased chest pain? New or increased shortness of breath? Perfect. Now we move on down for our sheath insertion and removal. Is your site soft? Yes or no? Do you have any complications? Perfect. No bleeding at site. Excellent. And now pulses.
Since this was at the right groin, you can close all of the others and just do the right pedal pulse. If they had to go into both sides, you would want both right pedal and left pedal here.
Thank you.
Mm-hmm.
Can you show them how to close one side?
You would also want to document whether it's Dopplerable, moderate, strong, whatever how you were checking
Your
this.
pulse assessment
But
is.
if you have an art line in, you would definitely want your pulse checks here. But if you don't need these other pulses, you can right click and complete the lines that you do not need. Clean up your flow sheet. So if you just want both pedal pulses, you can clean up the rest by right clicking.
Maybe, maybe not.
Why is it freezing? Well, it won't let me do the owners. Okay.
Oh, that's right. Maybe. Maybe that's a function within Epic.
Okay.
We're learning things here as we go. And then your VTE prophylaxis. I'm down at the bottom. That's kind of a no-brainer. You guys know how to document that. Just remember that if the patient does not have SCDs on and they have no contraindication, please put them on and document that information. Alteplase does not count as VTE prophylaxis. Now, let's say your patient is declining and they have a bleed and we need to put an art line in and an EVD. So Christy is going to scroll back up.
So you're going to want to add a row up here at the top left. Click on add a row, type in hemodynamic. So it's invasive hemodynamic monitoring, and click accept, and it should populate right underneath your vital signs. Then you're going to cascade that open, and you want your art line in if they have placed an art line, and you click add and accept, and now you have your art line. If your doctor has now placed an EVD, again you're going to add a row, and you're going to type in neuro, and it's neurological monitoring. Click accept. That should populate right underneath your art line, and then you can cascade that open. And if it's ICP you want, the waveform you want, the CPP, you will add those four, and it will populate right there in that neurological monitoring. This way it's all right with your vital signs, not down at the bottom of your your flow sheet.
The ultimate intent for this flow was to really put everything that you need in one location and to make your documentation a little bit more streamlined and a smoother process. Now, when you do your documentation, it doesn't change the times that things are required. So you can continue to use the paper flow or the checkoff sheet for your times. Alteplase documentation must occur with all of the appropriate pieces every 15 minutes times 2 hours from the initiation of Alteplase. Then every 30 minutes times 6 hours, then every hour times 16 hours. For thrombectomy, your neuro assessment will follow that same process. Your pulse and groin checks will be per the provider order. Typically that is Q15 times 4, Q30 times 4, Q1 hour times 4, then Q4 hours until discharge. So those pieces of information are important to remember as you complete your documentation. Anything I missed?
If you have any questions, don't hesitate to email Karen or myself.
And we will answer those to the best of our ability. Thank you guys.